90 degrees of flexion at the shoulder. Start out with the elbow flexed. I'm going to put a valgus stress into the elbow, in the forearm posteriorly. And I'm just going to quickly move him into extension, keeping that valgus force. And so what you're looking at with this one is a painful arc from about 120 to 70, so kind of in this range here, that it should reproduce that pain. You're going to have the patient lying on their back. Then you're going to come up into 90 degrees of shoulder flexion and elbow flexion. Use your elbow, and now supinate. Okay, which way did the hand go? Supination, I like it. What we're going to do is supinate the forearm, and then bring them out into extension. Supination, same thing, we're doing a valgus force. It's probably easier to stabilize out here. So I'm pushing the forearm out and then doing that. If they have rotary instability, they'll have apprehension there, that they feel like it's going to, the radial head is going to, or the elbow is unstable, and they'll feel like the elbow is going to pop out. For valgus stress here, am I reproducing the person's pain? I'm really looking for the ligamentous test. So we're going to supinate the arm. I'm going to lock it in with your elbow against your side. Come to that slight flexion. And if you'll hold, see how I put my thumbs like right in the cubital fossa here? Fingers are just distal to the epicondyles. I'm here, I've got his arm. All I have to do is twist my body to the left for a valgus stress, or to the right for a Varus stress. I've got a really good. That's on a nerve. I lean into it. I'm putting slack on this end of the system. If that reduces those symptoms, then that's a positive test. So they had to have the symptoms, reproduce the symptoms, and it had to be relieved by movement at a median nerve. Is wrist extension again. Make sure, particularly the first 3 fingers, so your thumb and 2 fingers, are fully extended. Wrist is fully extended. You're going to come out and back horizontal abduction. Head changes symptoms down in the hand. We said ulnar, median, and then radial is, they call it tip pleat. You're going to internally rotate, extend the elbow, flex the wrist. About the radial nerve wrapping around a quick active screen for the nerve entrapments. A super important piece of this is scapular depression. If you don't get good scapular depression, then you're not going to get a good, reliable technique. It's probably the thing that builds up the most tension. Take your elbow, put it right up over the shoulder, press the scapula until it doesn't depress anymore, and then dig your elbow into the table so that it's locked in there. Then you're just going to hold the arm. So I have his arm abducted out to 90 degrees. Next important thing is that the lateral 2 fingers, the index finger and the middle finger, and the thumb are fully extended. You'll put your index finger over the thumb and put the rest of your hand over those first 2 fingers, so that you've got the thumb and those fingers locked out into extension. At this scapula, I've got the wrist in extension, supinated. The thing I'm going to do is externally rotate until the end of range here. And so it's basically as far as your patient can go, not overstressing it, but just taking it as far as they'll go. Start extending the elbow out slowly. And then kind of find that point, right? So I'm going to back off, and we're going to find it again. Tell me right when it starts. Teach them how to move their head first, because when I ask you to later on, you're going to bring your head just back to the middle. It's easier for someone to bring their head back to the middle than it is to try to go towards the side. Supporting under the elbow, locking out his thumb, his first 2 fingers, wrist in extension, forearm in supination, externally rotate. There, we're going to find that point right where it starts, and now bring your ear towards my elbow, just like we did before. Good. And did that change anything? So remember we said that tip please position was the position for the radial nerve, and so we're going to put them in that position. The big challenge of this one is maintaining the internal rotation of the humerus, which is important, right? Because remember, you've got the radial nerve going along the spiral of the humerus, body into it. So I plant my foot far enough underneath that then when I lean into it, we got good scapular depression. I'm going to come around on the back side of his hand because ultimately we're going to flex and only deviate the wrist on the back side of his hand so I can get this position. We're going to come in here at the elbow and fully internally rotate the shoulder. So really try to catch like the epicondyle either here or with your thumb. Some way get a hold of a nice bony, so you're not just twisting the skin and the muscle around the arm. Fully internally rotate the humerus. I'm going to extend the forearm here first. So full internal rotation, elbow extended, wrist flexed and only deviated. And then I'm going to start bringing him out into shoulder abduction. Yeah, I mean, it can be anywhere along the arm.
Yeah, I didn't know if it was
but it's usually going to be through here. So you bring him all the way up into about 90 degrees of abduction and you still haven't gotten anything, you can actually take him down into shoulder extension as well, and that'll add. So that's for the radial nerve, and then for ulnar. And depress and plant your fist, lean into it. So now you've got a nice block there so they can't come up. You're going to let the elbow kind of rest on the crook between your abdomen and your thigh. The little finger and the ring finger. So just like we were paying attention with the medium ones earlier, now again being really important that you're keeping those extended. Pronate the forearm, so wrist extended, forearm pronated. And if you just think about overall, you're trying to bring the fingertips towards the ear. If you can put the palm on the ear, that's kind of what you're going for. Now when I come in, the fingers are going down towards the neck. So fingers towards the neck, palm to the ear is what you're going for. And then I'm going to, first thing I'm going to do is flex the elbow and get it all the way flexed. And then from here, if they still don't have any symptoms, then start abducting the shoulder up towards, so the hand's going up towards the ear. Don't lose the flexion though. So as you're lifting up, don't let the arm come out. You got to keep the elbow flexion. The techniques that we can do with it. What were the two types of techniques?
Glide and
gliders. Yep, gliders and tensioners. Right. So if we're going to do a tensioner first, and we said tensioners affect more directly to the nerve or more the pathway that the nerve runs through, the nerve itself. Tensioners and the difference in tensioners and gliders. Tensioners put tension through the epineurium of the nerve. So they kind of compress the nerve itself. And so they actually put a lot of tension, that's why they're called tensioners, on the dense connective tissue of the nerve. But one of the things that happens when you do that is it decreases the viscosity of the axoplasm, the fluid that flows through the nerve. So one of the thoughts is that by doing the tensioner, and you're kind of doing this repeated on and off compression of the nerve and decreasing the viscosity of the axoplasm, that helps the exoplasmic flow, helps with nerve healing and regeneration and whatever. We don't know for sure, but that's the thought behind doing that. The gliders, it doesn't put a lot of tension directly on the nerve, but what it does is the string and the straw, like you're talking about, moving it back and forth. So the idea is if there is something that's, some either adhesions that have formed or something, swelling, something in the area that is restricting the normal movement of the nerve, that gliders can help go back and forth through there and keep that mobility. I like to do those a lot after people have had spinal surgeries. Give glides as a kind of a prophylactic exercise to make sure they don't build up any neurotension. Because that's actually one of the things that happens after a lot of spinal surgeries, is you'll get dural adhesions, which can cause a lot of problems. Nerve, get in our position here. We're going to go out and find the point where we have the tension. And so we'll say it's right here. With a tensioner, I really only have to do one side of the nerve, right? I don't have to have his head moving with it, but I just need to put pressure on and off of that nerve. So a lot of times what we think about is if I think it's more, I think the problem is more proximal, I might keep the distal tendon fixed and have him do his head as the movement to really focus on that end of the nerve. If I think it's more something like carpal tunnel syndrome or compression in the forearm, I'm either going to do the elbow or the wrist as my treatment. Right to the point where we find the symptoms, and either a very gentle back and forth like an oscillation. Flex, come back to that point, flex, come back to that point. So you don't hold the position for a length of time. Again, you're cutting off the blood flow when you put nerves under tension, so usually about 5 seconds is about as much as you want to hold that. I kind of view it as like a tissue health perfusion sort of a thing, so lots and lots of repetitions. By convention, I'll usually do about 30 at a time, and I'll do a couple of bouts of it. To the point where you get symptoms, right? When I touch here, you're just barely pushing into it. And that's why you're going in real slow, and you find, here's that point where I find it, and I'm coming off, going right back to it. So you do the same thing, and so we can start him out by having him get his head movement. So I'm gonna, before I even get into the position, I'm gonna have him bring bring your ear towards me, and then back to the middle. So we can start out just like kind of more gentle, where he's not adding tension, he's taking off tension and going back to normal. Or we can make it a little more of a pull from the head, if I think it's more of a proximal kind of entrapment. And I want you to take your ear towards your other shoulder and then back to the middle. If they're doing more rotation than side bending, work with them and try to get that down first. We're gonna do the one where you're gonna bring your ear towards me and then back to the middle. Okay. So I'm gonna go to the point where we find the symptoms. So let's say it's right here. The first thing I want him to do is bring his ear towards me. I'm gonna take out a little bit more tension in there. So I'm pulling this way, and I'll take your head back to the middle, and then I'm letting up, back towards me. I'm going with him, just keep moving your head back and forth. I'm pacing his forearm movement with his head movement.